listening to the Massage Therapist Development Initiative. I'm Jamie Johnston.
And I am Eric Purvis. This is a podcast by massage therapists for massage therapists.
Our objective is to simplify how to be a more evidence-informed practitioner. Let's dig into this episode. We are back with another episode of the Massage Therapist Development Initiative, and we are pretty excited today to have our second ever guest. And very excited because this individual has influenced Eric and I a lot in our career through his website. And I remember when I first started reading some stuff on that website, I got pretty angry. Then I started to settle down and read it with a little bit more of an open mind, and it's helped me a lot in my career. So without further ado, we welcome Paul Ingraham to the podcast. Thanks for being here, Paul.
Thanks. Pleasure to be here.
Yeah, I remember I think there was a point in my career or with my blog anywhere where I thought, oh my God, I've made it. And I think I actually phoned Eric that day and was like, Paul Ingraham just referenced me in one of his blog posts on circulation.
Victory!
Like, I've made it. This is great.
I remember that. Jamie was like a giddy little boy on Christmas morning, and he was just like, "Oh my God!" He was so happy.
It's nice to be able to give you a moment like that, Jamie.
Yeah, I really appreciate it. I might have to frame it one day and put it up somewhere, but
you're going to run out of room. I'll be linking to you again. So,
oh, thanks.
There will only be the first time will only be once.
So great to have you on today, and we thought we'd kind of start out with just kind of talking about like the path that you took, because you were an RMT and then became this, influencer in our profession with your website painscience.org. And just how did you get to the point of being such a skeptic and questioning things and going through and deciding, okay, I'm going to start writing and publishing this content for other people?
Sure. .com, by the way, painscience.com.
Oh, I'm sorry.
No worries. I get it confused myself, and I changed the name a few years ago, and it's from the old saveyourself.ca, which lots of people still refer to. I had a good old friend, like somebody I know well and have for a long time, and he referred to my website saveyourself.ca just the other day.
Yeah.
6 years, dude. 6 years. I came to skepticism basically by getting fed up with stuff that I saw in the profession. I wasn't a skeptic in school. There was a contingent of good critical thinkers at OVCMT and Vernon in my class, and I wasn't one of them, which is kind of funny. Mm-hmm. They were calling out some BS that we were being taught, and for me, it was just a sideshow. I wasn't that interested. But later on, I got interested. Later on, I started to get frustrated with the pseudoscience that I saw in the profession and embracing some pretty silly stuff. And that's really saying something, because I wasn't a skeptic in the beginning, and didn't really know much about critical thinking, and yet I was seeing stuff in the profession that was so bonkers that it bothered even me, a non-skeptic at the time, and so it just progressed from there. And by roughly the mid 2000s, I had transitioned from being a pretty credulous guy. I believed a lot of weird stuff, and had a lot of magical thinking, but I graduated, and by the mid 2000s, I was writing frankly skeptical material and starting to really piss people off.
Yeah, nice.
I got a question. Yeah, it's just good, right?
I was going to say something that Eric was. So.
Okay, jump in. I was just, this is a question because I think Jamie and I both agree that I think most RMTs have been through that journey of acceptance to questioning to, once you kind of start to question, you start to realize there's a different truth there, a different narrative. My question for you, as someone who's been around this for a long time, is why do you still think that that pseudoscience is still so prevalent in our profession? Do you have any thoughts on that?
Cultural momentum, I think. Here in BC, there was a pretty strong push to make the profession more professional in the 80s and the 90s, particularly the 90s. And ironically, I think probably, at the time, the people who were pushing to make more of an alliance with medicine and mainstream healthcare maybe didn't realize that their biggest enemy was within. That it wasn't, the problem wasn't so much getting other medical professionals and patients and the public to accept massage therapy as a legitimate medical service and part of healthcare, but getting massage therapists themselves to think that and act like that. I think actually the public and even other healthcare professionals people love to love massage. I mean, they can trip over themselves being generous towards this profession. I saw that in a big fun way at a skeptics convention in Las Vegas in 2009, I think. And I was the token alternative medicine professional at that conference. Thousands of people there, huge thing. And these are people who love to debunk, some of them way too much. And they were so nice to me. I mean, they were just like, every time I turned around, they're like, well, massage is legitimate though, right? I mean, they had complete willingness to accept massage therapy as legitimate healthcare. They weren't skeptical about massage at all. I had to teach skeptics to be skeptical about massage because they were that eager to be okay with it, to like it. But at the same time, of course, everybody knows the cliche of Phoebe on Friends, the flaky massage therapist. That's also a big part of the identity of massage, and I think that's basically why we still have so much pseudoscience in the profession today. Because to be blunt, a lot of us are or were flakes. And I say that with love.
Yeah.
Because I am a former flake.
I've often thought about referring back to Friends and just developing a Tonka truck technique.
Yeah, you could probably sell that.
Yeah, we actually had a colleague actually who was one of your instructors, Paul, Sandra Mowat. Yeah, she remembers you, and we told her a couple weeks ago that you were coming on the show, and she was really excited, and she had good things to say. She had good memories about you. But one thing that she sent Jamie and I a message yesterday, I haven't responded to it yet, but she was saying kind of what you were saying is that the one of the problems of the barriers we have in the profession is the people that are attracted to it aren't necessarily skeptical or critical thinkers. There's a certain type of personality that's attracted to the profession, and who want to or have experiences in those type of things, and they have those beliefs that can be very difficult to unchange or to influence. And so it's good. Yeah. The conversation she had, is very similar to what you were saying. So it confirms our biases. So therefore it's got to be true.
Must be. Yeah. I mean, pseudoscience has its own momentum. The nature of things that we believe on faith is that they are rarely challenged. And once established, it's difficult for them to fall because, by their very nature, they're not being questioned. They're being accepted. It's, dogma is persistent by nature. And so we see a lot of Energizer bunnies in the world of snake oil and quackery and bullshit medicine. Because there's just no reason for these things to ever die or go away if they aren't questioned. And so it's really a strong feature of quackery that a lot of it is old. It goes way back, because as long as people can sell it, it just keeps getting sold. And that's really the only, quackery is more likely to die from market forces than critical thinking. Which is an interesting thought I've never actually had before.
Yeah, well, that's a pretty prolific one to come up with on the spot. But
it's kind of a cool thought, isn't it? Like, yeah. I mean, how many? If you look at the history of quackery, how many like full-blown snake oils? And I'm talking about stuff that like almost any modern person would say, yeah, that's bullshit. Like bloodletting, say. How many quackeries have died from critical analysis from science versus just people stopped buying them? be interesting to do a survey.
So it's interesting as we talk about quackery. I don't think it's just limited to massage. I think you could look at any of the manual therapy things, whether it's chirophysio, massage, whatever. And I think there's still a certain amount of quackery in all of that. It's not just limited to us as massage therapists.
Oh, of course not. Yeah.
Yeah.
Unfortunately, quackery is everywhere. Very widespread.
Yeah. I'm sure it probably is in medicine as well, just to some degree.
Mm-hmm.
Yeah.
Absolutely. Yeah. And I got exposed to a lot of that working with sciencebased-medicine.org. So
Right.
I went from being quite focused on issues with manual therapy to kind of getting a head explodey couple of years of learning about all kinds of nonsense throughout the world of healthcare.
Yeah. Wow. So when we talk about some of the nonsense in healthcare, one thing, and I know you've written one of your ebooks on it, we get to the topic of trigger points. And I know you prepared some information for us, and I'm really looking forward to hearing your take on it, because when Eric and I teach our course, it's one of the myths that we bring up in massage therapy, and I'm sure we don't do as good a job dissecting it as you'll be able to give us. So give us your take on trigger points.
There's a lot here, so we can talk a lot about this, and we will talk a lot about it, I suspect. For people following along, a lot of what I'm going to be talking about is coming straight out of one particularly large article called Trigger Point Doubts, and you can get to that article very easily, painscience.com/TP doubts, one word, TP for trigger point, TP doubts, and that'll take you to that article. And it's a monster. I think it's 14,000 words or so, and a lot of what I'm going to be talking about is straight from that article, which is it's all about the controversy about trigger points, and it just the idea that there even is controversy about trigger points. I think it's still a surprise to a lot of massage therapists. Do you think that's true? Do you think there's still a lot of massage therapists out there who are like, really, there's controversy about that?
Yeah, because I think it's still being taught the old Travell and Simons way in most of the schools still.
Yeah.
Yeah, it's actually one of the ones that when we teach, there's always like trying to have people think differently about pain and think differently about manual therapy and the role of what we do and what we're the least wrong understanding, and we'll bring a lot of those myths and and trigger points as one of them, and that seems to be, I would think Jamie probably agree, that's the one that creates the most pushback, or people are like, yeah, but it's this thing, and I know because I can feel it, and people seem, when you give them a different explanation, they seem okay with it, but it's definitely, I would say probably 90% of people, hey Jamie, at least it's the first time they've heard that it's not the way Travell taught us.
And I think part of why there's so much kickback is because people go in and do a treatment, and then they feel it's a successful treatment because the person typically feels better after, or they've felt that the tissue has changed under their hands after they've released a trigger point. So I think it's sort of one of those things where you're chipping away at their anecdotal evidence that they experience in their practice, and that can be a bit intimidating to people to think that they're not doing what they thought they were doing.
Yeah, I think I live in a little bit of a kind of an elitist bubble of social media influencers and very prominent expert people in the profession, and so I kind of get a skewed impression of current views on the topic of trigger points. I hear, I correspond with and hear from and see posts from people that are almost exclusively critical of the idea of trigger points. Lots and lots of skepticism, and it's easy for me to forget that there are legions of working massage therapists out there who not only don't have their own trigger point doubts, but weren't even aware that that's a thing.
That they should have a doubt.
That they should have a doubt, or that anyone has doubts about that. And it's partly, I think it's a large part of that is just the literal weight of those big red books. They're just so impressive. And the famous text by Travell and Simons are a huge influence to this day. And from a massage therapist perspective, they seem so serious and so weighty, so much gravitas, so much doctoring, so official, and how could how could that be wrong? Well, it could be wrong a lot of ways.
Yeah.
So I bring a comforting perspective. I got good news and bad news, massage therapists. The bad news is there is a lot of perfectly legitimate skepticism about what trigger points are, whether or not they exist, how they work, whether or not trigger point therapy is effective or legitimate. That's the bad news. Good news is I'm a moderate skeptic on this topic. There are actually quite a few experts who are, like full-blown dismissive of trigger points, angry about them, contemptuous, and again, speaking to the therapist who hasn't come across this topic before, you have no idea. there is some serious skepticism about this, and there are people who believe that you, as a trigger point therapist, are a quack. And so the good news is I don't think they're entirely right about that. And I have a very complicated and nuanced position, and I'm gonna discuss both sides, because what I care about is understanding. I want to know how it actually is. I want to know how this stuff works. I'm not interested in being on a team. I'm interested in understanding as best as I possibly can. So my trigger point doubts article is, that's a free article that stands on its own, but I also sell an ebook about trigger points, and I always have. It's responsible for, in a lot of ways, it financed the early years of painscience.com, the success of this website. It pays for my life, it pays for my career, along with 9 other books, but it's consistently been my bestseller since the beginning. I considered myself a trigger point therapist for a decade. Then I wrote a book about it, and I've been making a living on that for more than another decade. So I have a dog in this fight.
Mhm.
But I'm also really, really passionate about truth and learning. So despite that history and that background and that vested interest, I have been through, over the years, a huge upheaval of my beliefs and ideas. And, to cut to the chase, to make a very long story short, about 2010 to 2015, I basically stopped believing most of what I used to believe about trigger points. Almost everything that I had written in my book, almost everything that I did as a massage therapist, I threw out and revised. And it took years to rewrite that book bit by bit. And honestly, in some ways, I'm still doing it, to reflect, to update my position and to make it more balanced and more nuanced, and to strike a compromise between the criticism, much of which is completely fair, and the my lived reality, which is that I have really sore spots in my body that feel a lot better when they are rubbed, and I also have a great deal of education and experience about what that means, what that's all about. So it's been a long journey, and I've come full circle.
That's impressive. Because that's well, the amount of, like, I was going to ask at some point, like, how long does it take you to write one of your books?
Yeah.
But I think the truly impressive part of that is that you're always updating them as well when new information comes out. So, to think about the full circle that it's taken you to be able to write the original version and then keep reading research, keep looking at new stuff that comes out, and then update it, but also make it more palatable to the person who's reading it. That's an impressive dedication to the work that you do.
Yeah, thank you. And its updates are a huge part of what I do on painscience.com. Little marketing break here. I update everything on my website constantly. It's my job, it's my career, and that's why you should visit and buy books, because I never stop. And the answer to how long does it take to write a book, Well, I'm still writing all of them, so
Yeah.
we'll see. I mean, it literally never ends.
Yeah.
All 10 books are still being updated regularly. The Trigger Points book went through a particularly, like, it's the only one that's had like a full-blown existential crisis where I had, I'm looking at the introduction one day and I just shaking my head and saying, this is wrong. I can't keep publishing this.
Yeah.
Damn. That's the only time that's really happened. I have two books, not just one, two books about runner's knee, the two types, IT band syndrome and patellofemoral pain syndrome. And the IT band book did have a minor existential crisis at one point when, basically it was dueling studies. Some science came out and I'm like, that totally contradicts a major premise of my book. Yeah. And there was a big scramble to decide how to write about that, and of course I did, and I just wrote about the confusion. Well, we got some science that says this and we got some science that says that. What do we do? What do we make of that? But mostly all of the updating is just that we are still constantly learning, and there's highly relevant new science that emerges on an almost daily basis. And I'm going to segue back into Trigger Points here.
Perfect.
By making the very important point that musculoskeletal medicine and pain medicine is still shockingly primitive. We're not still learning, and there's not a great need for updating so much because there's just an immense amount of science being done. It's because we barely know anything. And so every bit of science that comes out is shining a light where no light has ever been shone before. And Trigger Points are a mystery, despite the existence of the Travell textbooks, despite the existence of several others, despite what seems to be and I completely forgive, any beginner to the world of scientific literature. You can be completely forgiven for thinking, but there's a ton of science. There's like, look at all this. Look at all the footnotes and references in these books. There's a ton of science, isn't there? It's kind of an illusion. Our knowledge is really amazingly primitive. And so there's a great need to constantly reevaluate. All knowledge is provisional. What we think we know, we usually don't. And as a simple example, I mentioned cringing reading the introduction to my own book a little while ago. The specific thing, I'll still remember it. I'll probably never forget this. It was a big moment in my career. The thing that I reacted to there was that I said that Trigger Points are based on good hard science. Good hard science. That was the impression that I had throughout my hands-on career. And that's what I had written down. And that's what was in the introduction to my book. And what I realized when I read that one day in like 2012 or something was, no, it is not good. It is not hard. And there is not much of it. It is, in fact, half bloody baked. Yeah. It is half-assed. And you can only come to that conclusion if you spend a lot of time looking at the science. And so there are many ways in which you realize as you study it, that there are problems. There's many ways to realize that it's all kind of half-baked, but one of the most basic is just that a tremendous amount of science, and this is just because science is hard. Science is hard. A tremendous amount of research is just crap. It's just poorly done, right? You go to a science fair, and some of the presentations that the high school students have put together are pretty good, and some of them are really not. And that's what science is like. That's what the real world of science is like. But it tends to be even worse in our field. In fact, musculoskeletal medicine, pain research specifically and particularly is kind of embarrassingly sloppy. with huge numbers of tiny, powerless little studies that don't really do much. They don't, that flashlight that I mentioned, they're kind of dim. They don't cast a lot of light. They're mostly published to pad resumes, and they're no good. They're done by amateurs, and peer review. Good peer reviewers would rip them to shreds. Mm-hmm. And so a lot of science, a lot of what you see, and you might think, well, look at all this science. Yeah, well, you can throw 80% of it out almost immediately. Yeah. And then what you're left with is just not enough, and it has other problems as well. Even good science really struggles to actually explain stuff. It's just takes biology is just really complicated, so it just takes a lot to understand what's going on. So now the introduction says trigger point science is half baked. And the spirit of the book now is, okay, what can we do with this mess? These ideas are out there. What can we, how can we learn about and talk about and use trigger point therapy in a way that is as humble as possible? Because it's clear that there's a lot we don't know.
So then my first question is, did you put a link to the movie Half Baked in with that?
I don't know the movie Half Baked, so no.
You gotta watch it.
Okay, I do that. I like every opportunity to link to pop culture that I can possibly take advantage of. I do in my writing.
Well, there's your homework for this afternoon. Watch Half Baked.
Watch Half Baked. Okay, and then link to it.
Yeah.
Will do.
So then, what do we do with mm-hmm. the current information, and especially as therapists, what changes do we need to make, or what changes do we not need to make?
Right. Number one is climb off your high horse and get real humble. Take humility seriously. I see a lot of paying lip service to humility in all of the alternative healthcare professions, and not a lot of actually being humble. For a profession that really prides itself on its humility and really loves to call out doctors for being arrogant, I sure do see a lot of overconfidence in massage therapy. So, getting more specific, try and keep it on the trigger point topic. Basically every therapist tells a story to their patients about what is going on and why we're doing this. And it's pretty important to understand that the story you're telling is probably wrong. It doesn't mean that what you're doing isn't worthwhile, but it probably does need to be framed differently. And you yourself probably really need to take seriously the possibility that you don't actually understand what you're doing. Which again, I'll emphasize as strongly as I can, doesn't mean it's not worth doing, but very important to start with, we're not actually sure. So being really specific, we don't know what trigger points are. We know that they are a phenomenon. They are a subjective phenomenon. We don't know that they're an objective phenomenon. So what I mean is that we absolutely know that people have sore spots. Trigger points, the words trigger point refer to a very common experience, which is that people frequently get sore spots. And this is where I'll interject that I am a chronic pain patient. I have been for 5 years. My entire life, I've been unusually triggery, prone to sore spots. So I absolutely know what I'm talking about when I say, yeah, sore spots are a thing that happens. Mm-hmm. And for the most part, they're just, spots on people's bodies that are puzzlingly sensitive, that come and go. They may not be sensitive next week. They may not have been sensitive last week. Occasionally, it seems that these sensitive spots also become associated with quite strong aching and stiffness, and at times downright fears. And they simply correlate. We don't understand that mechanistically. In the language of trigger points, we would talk about passive and active trigger points. Passive one being one that you only feel when it's poked, and active one being one that's broadcasting its existence. But I prefer to think of it in a very humble way as I don't even actually know if those things are linked, the aching and the stiffness versus the sore when poked. They seem to go together, but I don't actually know that they're the same phenomenon. So a trigger point is a thing. We call it a trigger point for lack of a better term, but we do not know what it is. The trigger point, the dominant trigger point theory, the Prevalence-Simons theory, is what I like to call, to dumb it down to, the mini cramp theory. It is a tiny, tiny little cramp. It is a piece of muscle tissue that is going and hurting and burning through a lot of metabolites and producing a lot of waste metabolites and irritating itself, and the vicious cycle theory, so that it keeps going, it pisses itself off. And so it goes and goes and goes. That's the conventional wisdom. That's the hypothesis that Prevalence-Simons had. And it's very important that in their entire life, they never called it more than a hypothesis. They were always open about the fact that they didn't actually know that that's how it works. And which is, by the way, one of the reasons why trigger points are not complete quackery. Because the Prevalence-Simons, for all their faults and for everything that they got wrong, they had a spirit of scientific investigation. They understood what a hypothesis was. They may have, particularly Travell, may have started to drink the Kool-Aid, as they say, late in her life and her career. But officially, she knew it was a hypothesis. Today, we know a lot more. And we know enough to know that we just don't understand how those sore spots actually work, what they actually are. And it is not clear that the mini cramp hypothesis is true. So you got an awful lot of therapists out there who are doing pretty detailed and specific things based on a hypothesis that is almost certainly half right at best. And that's pretty interesting.
It is. And often when we're teaching courses, we talk about the narratives behind many of the techniques that we learned in school. So this is clearly one of those ones where the narrative has to change if you're going to continue to treat trigger points in your practice. So
Right.
As we look at it, we look at the narrative behind the Prevalence-Simons, that it was, a knot in a muscle, and you push on it, and then as it eases, you push on it more. As it eases, you push on it more. At least that's how we were taught to treat them in school. So
Right.
with everything that you've looked at, how do we as a therapist change that narrative as we're talking to a patient?
The first thing that you change about the narrative is the level of certainty. So this is an extension of humility. Trigger point therapy should be presented to patients as experimental. And it's not a big deal. It's a bit of a, it's definitely a transition for a lot of therapists to start thinking and talking like that. But I promise it's not a big deal. I also promise that people are very accepting of humility when you tell a patient, we're not actually sure what's going on here. And I don't even know for sure if this will work, but I'm still going to charge you $1 a minute. People are amazingly accepting of that, but it's ethically really important. It's also important for your effectiveness as a therapist, because if you believe that you know what's going on, that will limit your options. That will make you less exploratory. That will make you less willing and able to, well, this doesn't seem to be doing the trick this way, so how about we try something completely different that's maybe inspired by a completely different idea about what's really going on here. And so it's pretty important ethically and intellectually to say, this is experimental. We don't know if it works. We don't know how it works. We've got some clues to go on and some good ideas, but basically you're paying for experimental therapy here, and we shouldn't keep doing it unless it actually achieves your goals. So I think that's a really important way to change the narrative. You do not have to, even if you know a ton about the uncertain science, we don't have to discuss it all with every patient. Some of them are curious, of course, but many of them are not. And, I'm not saying that we need to broadcast a bunch of dorky detail about what is really going on, but it is pretty important to, at some point, use that word or something equivalent, experimental. We don't know if this works, but we're going to try. We're going to cautiously and safely experiment with some sensory inputs here and see what happens. Because there's, if nothing else, we know that when we touch people, when we press on their tissues, they experience some pretty profound sensations. And mechanistically, we may not know exactly what a trigger point is or what's happening to it when we do that, but we can certainly see that there's an input and there's an output. We do something and people have experiences. So that's, that's a pretty good, I think I've covered the, how do we change the story?
Well, there's an interesting part to that as well, because when you talk about the ethics behind it, and I've seen some discussions on Facebook and different groups about this sort of thing, that if we're not giving them a more accurate description of what's going on, and say we're still using this old narrative, are we actually getting proper patient consent?
Yeah.
To treatment, which has to bring up the ethical side to this, that if they're not giving you consent to do exactly what you're describing, or if what you're describing is wrong, you're not actually getting patient consent, which is going to be difficult to deliver a safe, effective treatment without proper consent.
Yeah, no, you can't give informed consent without being informed, and the informed part often gets screwed up. To be honest, even the consent part does. In my practice, even back in the day, but before I was so high and mighty about the skepticism, it was pretty standard for me to tell people, look, I don't know that I can help. I don't know how effective what I'm doing is, so it's really important that we evaluate as we go. Is this worth it for you? Are you, if you're having any adverse reactions, are you okay with them? Are you getting enough, does it seem like you're getting enough benefit to justify the expense? Those were really important. But ultimately, what I was saying is that consent is often missing, and informed consent is super rare, because very, very few therapists are going to say to a patient, by the way, this is a really sketchy therapy and here's why, but I'd like to do it anyway. Are you cool with that? That's a rare conversation. And the part where you explain why, that's difficult communication, even for people who want to do it and are motivated to do it. That's not easy to communicate. That takes some practice and some skill.
I would think too that not trigger points aside, but I think any type of manual therapy, we could use that same, this is experimental, we don't know, right? And I like what you said there, Paul, about, it's got that curiosity, that exploration, that kind of uncertainty to see this might work, it might not work. And I think that's important. I think as a profession, I would love to see that more of us, just to accept that level of uncertainty, that this might work for you, it might not work for you. If it works, great. If it doesn't, let's try something else, rather than holding too tightly to our ideals. Because I think if we do that, then we run into these ethical concerns.
Yeah. And I can well imagine that you've got, listeners right now who are thinking, God, this is all so abstract. So let me make it a little more real. Like, why does it matter that we give a certain narrative? Let's go with a negative example and a positive example. So I'll start with the positive. One of the alternative ideas about what a sore spot is that it's kind of more related to phantom limb pain than anything wrong in the muscle, but it's kind of a ghostly projection of the brain. Not an all in your head pain, not what I mean at all, but just more pure sensory, pure neurology. that the body has decided to make a little patch of itself more sensitive as a function of protection. That pain is essentially synonymous with alarm, with the brain being cautious with tissue and warning you about it. If that's the case, okay, so this is just one of many possible ideas, but if that was the actual true narrative, let's just say, for the sake of argument, it's not a mini cramp, it's a little brain is worried about it spot. How does that change how you treat? Well, you could be gentler, for instance. You could make sure that your input is reassuring, that what you do with that trigger point is, it might be intense, it might produce strong, what we call good pain, but should never, ever, if this is what a trigger point really is, if that's what driving the sensitivity is your brain's concern about that tissue, then you should never push it into the holy shit territory. You should never make that person sweat or worry about what's going on and whether or not it's okay. So that's a quite a positive opportunity and an example of how the narrative, what you think is going on, can totally change your style. So that's an important idea. On the other side, narrative can also really screw with people. And I think that the obvious example that I see all the time is that patients who have been told that they have a quote unquote knot, that there's this physical thing in their muscle, that it's a cramp that they can rub out. Many of them get obsessed with beating the crap out of them. And I have seen some alarming cases of that. The canonical example for me was, relatively early in my career. This is probably 2002 or 3 or something. I had a patient who came in convinced by a previous therapist that he had a terrible knot in his shoulder, and he had broken through the skin, rubbing it. He had created an ulceration from over self-treatment. That was the tip of the iceberg. And this is something that, it's difficult for other people to relate to. And unless you happen to own a really, really popular, busy website, it's hard to appreciate the amount of mail you get. I get a lot of stuff from people all over the globe. And I don't know, like 5% of all email that I get about trigger points is from people who are clearly unhealthily obsessed with beating their trigger points into submission. And that is 100% a preventable adverse effect of the narrative. This isn't therapists hurting them directly. It's therapists who told them a story that they are now using to hurt themselves with. And one way or another, they've picked up all kinds of no pain, no gain messages about trigger points and the need to, in many cases, they literally believe they have to, quote unquote, destroy the trigger point. Yeah. And they get medieval, man. It's bad. I've seen some pretty horrifying examples of people who are just completely lost themselves down this rabbit hole. And it's bad enough, even if you accept that they are actually trying to treat mini cramps, even if you say, yeah, that's what is actually the problem. Where it gets really tragic is when you're pretty damn sure that that's not what's actually going on. They don't even have trigger points, and they are just lacerating their tissues desperately. Wow. It becomes a kind of optimistic self-flagellation that they're doing. So real harm can come from narrative. This is why it's not abstract. This is why it actually matters when you say anything, like even a few words to the patient about what we're doing and why, that you're not too overconfident, and you don't pitch a story that makes them think, maybe after this, I'm gonna, next week I gotta start beating the hell out of my own trigger points because that's cheaper. So I hope that's a good concrete example of why narrative matters.
I think it is. And I think one of the things that we talk about a lot is when a therapist says that to a patient, they're very well-meaning practitioners. At no
Mhm.
point did a
Oh,
practitioner
of course,
look
yeah.
at that person and say, this is the end goal that I want them beating the hell out of their own trigger
Right.
point. But it
Yeah.
still highlights the importance of having a more accurate narrative so that those ideas aren't getting planted in
Yeah.
people. So that, I mean, granted, that's probably a small outcome when we look at the large numbers, but we never want that type of an outcome.
Right.
You don't want that. You don't want to say that one thing so to that patient who then ends up lacerating themselves or ulcerating themselves
Mhm.
because you've implanted that thing even though you're trying to be helpful.
Yep.
I would question too, Paul, for you is what's your thoughts on like the Quintner and Cohen papers about the cutaneous nerves and the trigger point ideas around that? Do you want to share
Sure.
your thought?
Yeah. So John Trigger Points Are Bogus Quintner is the primary academic source for most modern skepticism about trigger points. He wrote a scientific paper with a couple other people. Oh gosh, how far back are we going? Probably 20 years.
I think I think was when the first
Yeah,
came out. Yeah.
yeah. And it was it was highly skeptical. It was basically raising some concerns about the hypothesis and proposing an alternative. And then the same authors published, kind of rebooted the paper just a few years ago, and it was in quite a prominent journal, high impact factor, and had a tremendous influence. The paper proposes an alternative hypothesis about what these sore spots are and how they work. And it could be right, but I think a really important thing to understand about that paper that I don't see discussed often enough is that they have no evidence for their hypothesis. Really, the only thing their hypothesis has going for it is that it's a clear, specific, testable hypothesis, but it hasn't been tested, and so it remains just another idea about what's going on. And that idea is basically that it's neuropathy, that it's irritated nerve trunks. And there's things I like about the hypothesis. There's things I don't like about the hypothesis. And the thing that I most dislike about it, that I find that it's disingenuous to be so skeptical of the mini cramp hypothesis and then turn around and propose something that is essentially has the same problem, which is, so why are all of these nerves in trouble? It's just moving from one possible mechanistic explanation to another. One of their major beefs with the mini cramp hypothesis is, why is it happening? What is the problem with this? Why are so many muscles screwed up like this? But you can ask exactly the same thing about the idea that it's just a bunch of irritated nerves. Seriously, we have pinched nerves all over our bodies all the time. Why? what's going on there? It's both are possible, but both are also equally without any obvious explanation. They both require this little leap of faith to say, and then something bad happened, and we're not sure why. So, yeah, it could be. It could be aching, irritated nerves. That's a thing. I'll give a really interesting example. This is just a clinical example that I find particularly fascinating. I think probably every practicing massage therapist who knows the slightest thing about trigger point therapy knows that a really, really common sore spot is just inferior and lateral to the PSIS, to your back dimples. I don't talk clinical terminology a lot anymore these days, so I was like, am I going to get this out?
Back dimples is totally acceptable.
I was wondering if I could remember PSIS, but yes, I can. So that spot where the top edge of the glute max attaches to the pelvis, that's a really common achy spot, and it gets targeted as a place that harbors trigger points a lot. But there's another thing that happens routinely in that area that presents pretty much identically to that achy, sensitive pain, and that is cluneal neuropathy. The cluneal nerves, little tiny superficial nerves that jump over the sacroiliac joint, sometimes get snagged, slightly impinged, wrapped up in connective tissue a little too tightly, which is basically a perfect example of what Quintner and Cohen and Bove proposed. Irritate a nerve, and you might not get frank neuropathy with numbness, tingling, weakness, etc. You might just get a little bit of sensitivity and aching. And that's exactly what cluneal neuropathy does. I first came across this a couple of years ago. I was, reading some miscellaneous literature while I was working on my low back pain book, and I saw this, formal case study published in a journal about somebody who had very persistent, back pain. And I'm reading and I'm thinking, gosh, if I'd been treating that person, I absolutely would have treated her like she had trigger points in her butt. She didn't. She had cluneal neuropathy, and someone finally figured that out and cured her. Very proper cure, lasting total relief with a minor surgical release of the cluneal nerves. So here again, we see the importance of narrative. Oh, you've got symptoms that sound a lot like trigger points. Must be a mini cramp. No, it wasn't. It wasn't a mini cramp. It was irritated nerves, very clearly, which we now, we know after the fact because a very specific surgical treatment worked so well for that patient. So that, of course, made me wonder, well, how much of that is going on? How many other examples are there like that? How much subclinical, or subtle neuropathy is there? And how much overlap is there between subtle neuropathy and Quintner and Cohen and Bove's hypothesis? Could we have, at one end, we've got capital N neuropathy, like carpal tunnel syndrome, where you can't even close your hand and it screams at night and it's bad, right? And then in the middle, you've got subtle sensory disturbances, aching, sensitivity. And then maybe we've got a lot of really quite minor, usually minor sensitivity. Because maybe we're prone to minor neuropathy, and maybe for every nasty neuropathy, there's 100 subtle ones. Maybe. If that was true, I'd sure want to know, but no one does.
Well, I haven't heard any of those things before, so you just educated me.
That's the goal. That's why we're here.
That's right.
No, that's great. Yeah, that's great. I love that. I love that description and the skepticism of that too, because I think it's easy to jump too hard into one narrative that you like. Like, I know for me, reading that Quintner stuff, I was like, I like this. This makes way more sense to me. Cranky nerves. But then, you gotta take a step back and say, okay, am I just using that same reasoning for this because I like this better? But it's following the same reasoning process as you would be for the Travell thing. So I like that. I think I'm really glad you brought that that perspective. People,
But go ahead, Paul.
There are about 8 to 12 other ideas about what those sore spots are.
But it kind of, I don't know, funny is the word, but as you were talking about it and you're talking about the pinched nerves, I wonder about the narrative around that as well, because I think in the same token, all too often we have that person that comes in and go, oh, I pinched a nerve in my neck.
Yep.
When that's not at all what has happened. But maybe a well-meaning practitioner in the past has said that to them, and they automatically associate that pain in that area that, oh, I pinched a nerve again.
Yeah. And in fact, I think you touch on something very important here, which is people's awareness of the narrative of neuropathy is much greater than their awareness of the narrative of mini cramps in their muscles. Trigger points is an obscure thing that a few people in our society encounter when they go to a massage therapist. Neuropathy is, everybody knows about nerves and everybody fears them getting pinched. I have a whole article based on the idea of nerve fear. I had this is a story I love to tell because it's got a great Italian accent in it, which I'll probably botch. But I had this elderly Italian client who was obsessed with nerves. He thought everything was nerve pain, and it didn't matter what I told him. My narrative got drowned out by his narrative every time. At that time, I was telling the trigger point story, and I'd say, well, "Okay, so you just got a trigger point here," and he'd go, "Oh yeah, oh yeah," and then 2 minutes later, he's like, "So that's a nerve, eh?" That's a nerve. He was obsessed with nerves. It didn't matter how much I would talk about trigger points. He'd be just like back to, okay, I got a nerve problem. And that's a thing, if you tell people that they've got any kind of nerve problem, they will cling to that because it sounds plausible to them. Yep. Because it's a thing they've heard of, because it is a thing, right? Like nerves do get pinched. Carpal tunnel syndrome is a thing. The sciatic nerve can get into trouble. Neuropathy is a real problem and a thing that comes up in medicine quite often, but it's probably only about 10% as common as people think. Common, but not as common as they think.
What I love about that story is that it really shows the melting pot that is Canada, that this man with an Italian accent is still using A.
Yeah, he did. It was such a cliche. A very sweet and charming cliche. It was lovely.
That's amazing.
One nice thing about the nerve narrative, though, is that it doesn't suggest any obvious self-treatment that people abuse themselves with, which is, it's an important thing to note about any narrative. Does your story about what's going on give people something, does it suggest a self-treatment that they're going to botch at home? Always something to be aware of.
Wow. Yeah. And I think it makes a lot more sense too. I think it's a lot easier if somebody has a idea that maybe their pain, that their ongoing pain has to do with a cranky nerve versus like something in the muscle tissue that needs to be beat out of them. It probably makes them less likely to try and smash their nerve to bits.
Exactly. Yeah. If anything, they want less pressure on that nerve, not more.
Yeah.
Another really interesting idea that intersects with that, and this is, we really focus on the mechanistic aspect of neuropathy, that the nerve is physically bothered in some way, but it's really important to understand. This is another great example. Okay, the whole theme of this show now is narrative. It's all about narrative. Even within the world of neuropathy, you can tell different stories about why it's a problem. And, in the case of the cluneal neuropathy, it seems like there's this very obvious story to tell about, the nerve was in physical trouble, but was it just vulnerable biologically to a relatively normal anatomical situation? This is another completely different way of understanding neuropathy, and probably valid to some extent, which is that, that woman's cluneal nerves may not actually have been in very different physical circumstances than anyone else. The difference might have been that for subtle, messy, wet biochemical reasons, physiological reasons, her nerve was too easy to bother. And if that's the case, then freeing it is a way to help. But is it actually solving the problem? This is the concept of root cause that alternative medicine is so fond of, but also so reluctant to actually truly explore, because true root causes are really complicated and often very medical in nature. So systemic inflammation, for instance, may be the real problem with that patient. That perhaps she has, for instance, as a simplistic model, metabolic syndrome, overweight, diabetic, pre-diabetic, risk for heart disease, systemic inflammation is up. She's got 10 nerves. They're right on the edge of being just a little too inflamed for their particular circumstances at that time. And one of them tips over. Now she's got neuropathy. It is neuropathy, take away the scare quotes. But it's not because the nerve is pinched. It's because she's physiologically vulnerable. And that is a very different thing. So that also intersects with trigger points, in that we see such huge differences between people. Some people seem extremely triggery, very prone to having sore spots, while others don't at all. There are people who don't have any idea what you're talking about. And by the way, just going to take a little shot at the skeptics here. I kind of suspect, I have the impression that a lot of the people who are most skeptical about trigger points are people who haven't suffered from them. And it's when you've lived through a lot of these fierce sore spots, it's a thing. It's really a thing. Lost my train of thought. Oh yeah, some people very triggery, other people not so much. Why? Maybe it has nothing to do with the mini cramp or the pseudoneuropathy. Maybe it's the vulnerability. Maybe it's systemic physiology, which is a very hard problem to tackle.
I love the points that you make, because one of the things that we often talk about is validating the person in front of you and their experience, and also just treating the person in front of you. I think too often we have our certain techniques that we use, and we think we're going to fix everybody, but we're focusing more on the technique rather than the person. So being able to look and say, hey, there's probably maybe some stuff that I don't even understand that's going on with this person, but let's just treat what they've got going on and validate the experience that they're going through, even though I might not be able to relate to it.
Right. Mm-hmm. Absolutely.
I think that kind of leads into a question that I wanted to ask Paul, is that, the role of RMTs in kind of musculoskeletal care or treatment. Obviously there's a lot of work to do. There's a lot of narratives and ideas that need to be addressed. What are your thoughts about our ability to, if we could make those changes in whether the culture or the education, do you see massage as being like a viable option for people that live with pain?
Meaning an important therapy, an important part of
the
world. Mm-hmm. Yeah, and I'm in a pretty good position to, speaking as a chronic pain patient with a massage therapist, actually not, she retired when the pandemic started. She was ready to stop anyway, probably only would have lasted another year or two, tired hands. And then the pandemic started, and that was that. But she had been, my regular massage therapist for 4 years, right through the worst of my own chronic pain, through the early days of it. And it's a fascinating position to be in, right? I am the publisher of a website that many massage therapists perceive as a massage hating website. It's not, by the way. Yep. I love massage, but a lot of what I write is so skeptical, and so there's so much science and so much critical thinking that a lot of people get the impression that I'm anti-massage, and I piss a lot of massage therapists off, like yourself in the beginning. So how weird for me to be in the position of saying there's a lot of problems with massage, a lot of things we think don't work as nearly as well as we think they do. They don't, if they do work, they don't work for the reasons that we think they do. And yet here I am as a chronic pain patient, pretty much desperate for my weekly massage. Fascinating. I concealed my identity from that massage therapist when I started, which became a source of great comedy later on.
I was going to say, how intimidated was she when you walked through the door?
Well, seriously, it is a problem, right? Like when I go to a massage therapist, if they know who I am, it's a problem, right? It is going to change the therapeutic interaction. It's just the most notorious critic of my profession on the table. Just relax right into this. So I've done this a few times where I don't tell them who I am. And when I started with this therapist, I loved her. I thought she was fantastic, which isn't a consistent experience. I am critical, and I have had massages that I was not satisfied with. Yep. And I really enjoyed her work. And so after about 2 months, I said, I got a confession. My name is not John. And we had a good laugh about it. She thought it was delightful, and it turned out she did know my website, and she did know who I was, and it was quite this funny revelation for her to discover. Anyway, chronic pain guy, love my massage because for the very simple reason I think that nothing else matters. You can throw out all the other stuff. You can take 98% of my writing about massage and massage science and just say, so what? It's a very pleasurable experience when done right. And for the chronic pain patient, pleasure is a pleasure. I mean, it's just being able to feel nice for an hour is priceless. And then you can work your way up from there. Because I'm triggery, I frequently have the experience with any nice massage of whatever the hell is going on. A massage therapist stumbles on a spot that feels really profound to me, and I want to punctuate that. And that we've all had the experience. Most of us have had the experience of, wow, that's a sweet spot. That feels important to me somehow, and no one can articulate it. How is it important? I don't know. It just feels important. Before I was in terrible pain all the time, I'd had that experience plenty of times. I knew what it was like, but afterwards it takes on a whole new significance. And again, this is what I mean about be careful about being skeptical about profound sensory experiences you haven't had. There's, no one's ever going to be able to study this subjective sensation. You can't do that. But as a chronic pain patient, I can tell you how emotionally important it was to have those itches scratched. Those sensations were so profound and so sweet. Even if I did, literally, even if I went right back to where I was immediately after the appointment, zero efficacy in terms of lasting results, which wasn't the case. But even if it was, I would have placed a very high value on those sensory experiences. And I can't tell you why. I honestly can't tell you why. Why does that matter? Why does it matter that she finds a spot and goes, is that it? And I go, yeah, well, a little to the left. Oh God, that's it. Yeah. Oh, wow. I don't know what's going on when I'm having that experience. I don't know why my nervous system thinks it is the most important possible thing I could be doing at that moment. But it does. That experience is profound. So there's a whole lot of just sensory significance to the massage experience, which is one reason why I counsel massage therapists to throw out all the narratives, get super humble, stop talking about how anything works, and just focus on delivering a delicious sensory experience. That is good therapy. We don't have to be technical and advanced. We can deliver amazing sensory experiences. And that is, for the nervous system, a lot of nutrition, a lot to work with. When you provide a lot of novel sensory input, it's clear that we don't understand what our bodies do with that, but it is clear they do something with it. Because invariably, I would get off that table every year for years, every week for years, sometimes twice a week. And I'm lighter. I walk better. And it never lasted. I'm a chronic pain patient, but it almost always gave me 1 to 5 days of relief, of significant relief. And so, here I am, this notorious skeptic about massage, who is absolutely entranced with that effect and willing to spend thousands of dollars on that effect, even though it was transient.
That's amazing. And I think just to add to that, we speak regularly about how, because of the amount of time that we get to spend with people as massage therapists, and because of the effects that you just talked about, we have a true belief that we have an opportunity to be leaders in the musculoskeletal healthcare system. As opposed to maybe some of the other manual therapy. And one point that you touched on, I don't remember how you exactly said it, but we kind of always put ourselves at the bottom of the hierarchy because we're not as
Mhm.
technical maybe as the people who have gone to university and these type of things, but we still believe we can be leaders in the field. How do you feel about that?
I think the potential is there. I think that the profession has to grow up a lot to actually assume that role and function in that role. Obviously, there's already a sort of pseudo counseling role, and not talking about violating scope of practice. We're not psychologists. I just noticed how I keep saying we like I'm still an RMT, which is interesting.
We consider you an RMT.
Well, and it's because I realize who I'm addressing, right? I know your audience. You've got presumably a lot of RMTs in your audience, and the reality is I don't normally these days think of myself like a clinician. I wouldn't normally say we, but because I'm talking to an audience, it's like, all right, we, us, club, belong.
Yes, exactly.
Anyway, we aren't psychologists, but there's obviously psychological and emotional value to spending pleasant time with a compassionate human being who's trying to help us, and so we have that. To expand into the role of coach and educator is exactly what I aspire to for the profession. I think that's exactly where it should go, but honestly, I'm quite cynical and pessimistic about whether or not massage therapists will ever learn enough to take on that role in a more serious way. We need basically massage therapists need to be a lot more. We need better training and a lot less BS in our toolkit before we can have any realistic hope of taking on that role.
Yeah.
I would agree 100% with that statement. I mean, that confirms what I like. That's how I think very similarly to that, Paul. So it's good to hear from you that, the kind of things that Jamie and I are involved with and stuff we're trying to do is, makes sense to somebody like yourself who's, been around for a long time and is, has such a great understanding of the profession and as well as the science and the pseudoscience that surrounds it. So that's great.
And I think in addition to that, I think the work that you're doing is also lending itself to the profession for us to be able to build things up, because especially, coming from an RMT who is writing and skeptical and doing as much as you can to not only educate the public, but educate other manual therapists, it goes a long way. So thank you for the effort that you're putting into all the stuff that you do.
Thank you. I feel like my job is to work on it from the outside, and it's very clear that there are still people in the profession like yourselves, and Bodie Haraldson here in BC would be another fantastic example of people who are frustrated and cynical and concerned, but also working their butts off to make it better. And to those of us who have left, it seems like a bit of a Sisyphean task, but we greatly admire that you are still in there working hard on it. But man, you got a big hill to climb.
Yeah, we do.
We are seeing a lot of change, though. I think in the last few years, there has been, it seems, it's not just one or two or three people, but it seems to be that there's a growing group of therapists that are starting to call out the bullshit, and they're starting to want more and starting to, teach and be vocal. And whereas I think for a long time, maybe it was just my world was smaller. I saw very few people, and I knew Bodie and I knew your stuff that you were doing, Paul, and there's a few other people out there. But not a lot. But now it seems like everywhere you go, you're hearing more and more people that are starting to be like, "What the hell's what's up with our profession? Why are we still learning this stuff? Why are these narratives still going on?" So I think it's that mass is growing slowly.
I think you're right. It does seem like there's more.
Yeah,
and the acceptance is growing.
Yeah.
When we first started teaching, there was people crying when we said that you don't increase circulation. Because we thought that we just ripped their whole practice apart. Whereas now they're like, yeah, okay, whatever. People are far more accepting of the updated material. So that I think that's a positive for the profession as well.
Yeah. Oh, that's great to hear. I mean, honestly, that's fantastic, because and I've seen that. I've gotten those emails. You're destroying me. You're destroying my career. No, I'm just changing the story a little bit. That's all.
I'm glad I'm not the only one that's gotten those, Paul.
Oh no, long history. I get a lot less hate mail than I used to, but I used to get bags full of it, virtual bags of hate mail.
Yeah.
And I've gotten a lot more diplomatic on pain science over the years.
Yeah.
Something I want to just wedge in here at the end, feels like we're reaching a natural stopping point, but I really want, because I think I know what kind of audience I'm addressing here. Maybe a bunch of people who haven't encountered a lot of skepticism about massage. I really want to say, as a former card-carrying skeptic and a former massage therapist, I really want to point out a couple of problems with chronic amateur skepticism. Like everything in life, like massage, like skepticism, like everything, you can do it badly. And I see a lot of it being done badly. I've kind of distanced myself from the world of skepticism. I don't actually consider myself a member of that community anymore. I have inherited skills, especially thinking skills, from my time in that community, but I have gotten quite disillusioned. I particularly have seen too much knee-jerk skepticism about trigger points. Not all sketchy ideas are equally sketchy. And I see trigger points being lumped in with things that are 10 times worse. That, the science of trigger points is half-baked, which sounds bad, but it's a lot more baked than 1/10 baked. And there is good information and interesting stuff to learn about this. And I've gotten pretty tired on social media of trigger points being a punching bag for amateur skeptics who just never have anything to say about it except, a couple of really stock talking points that are frankly simplistic and not nuanced and very clearly mostly just what we call virtue signaling these days. They are talking more to their fellow skeptics than anyone else, just saying, I'm in that club, and I'm going to show that I'm in that club by being really dismissive about trigger points. And I've gotten tired of that. And I can tell you, as a former serious skeptic, and by serious, I mean I've palled around with, and I am still good friends with some of the most prominent skeptics in the world. These are really bright people that I deeply respect. They exhibit mature, sophisticated, advanced critical thinking skills. And I see, in contrast to that there are lots of skeptics out there who I consider to be amateurish. They are not nuanced. They are not skilled. They don't know as much as they think they do. They're oblivious to much of the history of the skeptical movement, what it means, what it's for, and worse. There's some egregious misogynists. There are terrible windbags. There are bullies. So I just really want, I am a skeptic, and I am seen and perceived by many, many people in the world as being a critic of massage therapy. But I really want to say, I try to strike a balance and get into the middle of that. I don't want to be a reflexive skeptic ever. And when I started to see too much of that, I started backing away. And nowhere is this more clear than my work on trigger points, where I absolutely believe there are serious problems with how it's done, how well it works, what we think it is. But at the same time, sore spots are really a thing. And I truly believe that framed properly, massage therapists can and should still work with the idea.
I think that's a great way to end, Paul.
Brilliant.
A great outro there. Great.
Punctuation mark.
Yeah. Again, we can't thank you enough for coming on today and sharing your knowledge.
It's a pleasure.
I have several thank yous to give you. One for saying that I look like Matt Damon when we weren't on screen. I appreciate that. But just
how could I not say it? I mean, it's obvious.
Well, I appreciate it. But just the fact that you're willing to take your time and spend your time with us and share your knowledge is beneficial, not just for us, but for the profession as well. So please keep doing what you're doing, and we're all continuing to learn from you. So we really appreciate your time and what you're doing.
Thank you. Much appreciated.
Thanks for
And
being
all I want in return is for people to visit painscience.com, read some stuff, learn some things, and send me a question or a request or a suggestion, because above all, it's always evolving. And the number one way that I choose these days to update an article is because someone wrote to me and said, yeah, but what about blank? Or is this right? I don't quite get this. I'm inspired by the questions, suggestions, and criticisms that I get. So please don't hesitate to do that.
Perfect. And we'll be sure to put links to your site and the Trigger Point book and that in the show notes so that people have access to that. And we'll be sure to share it on social media and that as well too.
So that people can buy a book.
Yeah, exactly. Okay.
That's the really important thing.
We'll support Paul's living so that he can keep educating all of us. That's great.
Thanks, guys.
Okay. Thanks again.
Okay. Bye.
Thanks.
We hope you enjoyed this podcast. These kind of topics are what we are all about. If you'd like to learn more, go to our websites.
themtdc.com or ericpurvis.com. If you know of any other therapists that could benefit from this, please tell them to subscribe.